John introduced that as saying running a 1 in 10 rota with fewer than 10 doctors. Is that possible?
I don't know, I'd have to see. I think you'd have to run it, but it
Not for everyone on the rota, clearly, but for
Yeah.
the 1 or 2 IST pilot trainees, it might be.
yeah, so if that is the case, then yes, it might be. Again, there are so many different constraints and so many different factors, and it requires quite a lot of discussion and negotiation and possibly a bit of open-mindedness to see what areas you're quite happy to be relaxed about and what areas are absolute red lines. And this is where it really needs quite a lot of input from you as trainers, what you see as what is absolutely core to getting these trainees their training, and also that's their needs, and then what they need to sort of not burn out and make sure that they sort of continue. And then you've got the compliance need and then the service needs as well. So there are a number of constraints, but if we can do it in ED, I'm pretty sure we can do it for surgery.
Question has come up on there may be peaks and troughs through a week allowing rosters to work, but what happens when there's a sudden unplanned increase in demand?
So yeah, that's a really good question. So you can plan for that. There's a lot of research in HR literature saying that if you have at least a 5% leeway in staffing, you can accommodate for peaks and troughs, for short-term peaks and troughs. So I think when the nursing staff do their off-duty, they always add a surplus of 20% headcount, if that's correct. I don't know if that's changed at all. So I think in theatre it's about 20%, on the ward it's an extra 16% increase in headcount. And just overall in the literature it says if there's a decrease in, if there's an increase of vacancy rate, or if there isn't leeway of at least 5%, then you run into problems operationally and financially. So some rotas will have a float registrar, and that could be a rotating thing. So as long as you plan for that, you absolutely can accommodate for short-term peaks and troughs.
And I'd had a sort of similar thing in reverse, really. We run most medical rotas on the assumption that nobody ever goes off sick. And
Yes.
historically
Yeah.
that was the case, but that is not the case anymore. Increasingly, junior doctors do take time off sick. Presumably the same principles apply.
So in the longer version of that talk, I do talk about how much of those 4.6 full-time equivalents you actually have in terms of man hours on the shop floor, and how you need to account for that in your rotas or actually rosters. I don't know if anyone's worked in Australia, but Australia, they have a sort of rule where you have the 20-80 rule, so 80% of your time should be clinical, 20% teaching, audit, etc. And that's actually in their roster or rota, depending where it is. So it's already allocated, whereas I think if you look at most rotas these days, it's purely 100% clinical. I think there are very few that are now starting to realise that even juniors need SBA time. So you need to account for that leeway.
Oh, the surgical training guidance always had what you would call SBA time in it. There was always the study half day and things like that. Question at the back.
Thanks, Ezra. So I'll give you an example of how complicated I think it will be for most surgical departments. We have a 1 in 10 rota, but we have trainees that are based in GI, in vascular, in urology, in breast surgery. So we not only have to take into account the need to cover the on-calls, the need for elective daytime training, which is theatres and clinics and other activities, including training activities. We also have to take into account that within their departments, at different tiers, they need to ensure adequate cover. So a small department might have 1 registrar or 2 registrars, a couple of core trainee or equivalents, and a couple of F1s, so they can't all be off at the same time. And I think you might have had it back to front where you think that surgery is going to be easier than ED. No, but I think you're right. It would need a software program to accommodate all of that, and I'm struggling to see how we get from a system that works well in ED, in your study, to one that'll apply well to a lot of surgical on-call rosters.
Yeah, so I think the only bit where it's slightly easier than ED is that I've seen vacancy rates in ED of up to 70% in a department. I don't think surgery is that bad yet. So that's the only thing. But surgery is definitely one of the most complex areas of managing a rota or deploying a workforce. And this is where I think it's quite exciting, because I think we have got a lot of scope to really try lots of new things. So if we do go back to one of the slides, right, when I showed you this is a roster, you just allocate the staff. You have your activity on the y-axis, day shifts, night shifts, clinic, etc. If you list your activity and you know how much of that can be done by a doctor, how much of that can be done by an ANP or a nurse, you can then actually roster appropriately to make sure that the doctors get what they need in terms of training and the nurses also get what they need, because they will be providing a tranche of that workload. I don't think it's going to be easy, and one of the biggest things that I think is going to be a challenge is how do you ensure the continuity of training and continuity of care without compromising on any fatigue indices or compliance. So I'm quite looking forward to seeing how that pans out, really.
John, you wanted to come in?
One of the other versions of that talk that I heard, Azra said that this modelling can take into account as many as 100 different factors, different axes, different requirements on the roster. So I'd say that the complexity you hint at there, and probably just touch the surface of, is exactly why this sort of approach might be really useful. Now, I've asked Azra to look at the working arrangements for the 2 IST sites in London, and I hope that that will provide some lessons that might help all of us in the room as it pans out.
Question there?
We've come up from Norwich and we've brought our head of medical staffing, Esther, who's sitting at the front there, who's writing notes, and which is excellent.
She's hiding.
And so the nitty-gritty is, that's a very interesting talk. How do we get hold of software like that? And what she's going to be interested in is how much does it cost?
Okay, yeah, that's fair enough. So we're not commercial yet, and we are really actually have got a very, very tight work plan to get to that within the next 2 years. I think the key thing is to actually try it out in different settings, like in surgery, because surgery is actually economically for a hospital, it is the biggest income generator for a hospital. But if you don't manage medicine very well, it will impinge on the service provision for surgery. So I think the business case that we've made for hospitals so far has been quite clear. And certainly for the Whittington, we actually did the pilot over a year ago and they're now a paying client. We just want to cover some of the costs. What we have been charging, and it's just purely to run the software, because actually if you run the solver, there are 3 solvers that can actually do this in the world, and one of the solvers that we're using is relatively open source. If you run it at certain times, it can cost thousands and thousands of pounds, hundreds of thousands in some areas. So I think if we can just demonstrate that we can recoup some of that cost, it doesn't really matter as long as we are demonstrating there is a demand and we're providing a benefit. So I think we're just open to anyone who's interested. We want to collaborate and work with hospitals. We've got the Whittington as a partner, and we're looking for more sites really to try this out. So I'm happy to have a chat afterwards. One
last question across there.
Firstly, thank you. That was a great talk and really well presented and really easy to understand. I actually don't think it's as complex as previously been asked. I think actually within surgery it might be much more straightforward than we think. But just one specific question. What was the satisfaction for the trainees in A&E after this roster, after you'd produced this roster? Was it better, the same, or was it actually worse than from the traditional rotas?
So this was during the time, we piloted it during the time of the strikes and the junior doctor contract negotiations. So juniors were very pissed off. And one of our HR professors, we managed to include some questions that were sort of control questions to accommodate for people who were generally miserable and see if we can actually make a difference. The biggest thing they were satisfied with was autonomy in choice of leave. And everything else sort of paled into comparison. And then when we showed them what they would have gotten with a rota, then it became quite apparent that actually this was far superior. The only sort of limiting factor is that these were FY2s and quite junior SHOs. So the majority of them were FY2s, but the ones who were GP VTS trainees, who have sort of seen how the NHS normally works, I think their satisfaction rates were much higher than the rest. So I have to just put it in context, really.
Great. I think we need to call it a halt there. Thank you very much. Thank you for your presentation. You might have quite a few people tapping you on the shoulder asking if they can collaborate with you, although I suspect they'll want to do it for free, I'm afraid.